this, there was a huge gap between block 3 and block 4. So I had to do a pretty extensive anatomy review just to get folks caught up to speed. Now, as I talked with Major Davalos, he told me that I don't need to do as extensive a review because you guys have got this covered. And I was proctoring your last test, and you guys did very well. Which tells me that you remembered everything that Major Davalos taught. Clear statement? Perfect. Wow, he's in the back of the room, so just so you know. Okay. So before we start, here's what I like to do, just so you guys understand what you can expect from me and you know what I expect from you, right? Just to be clear. Couple of admin notes. So if you're not going to be present when I'm teaching, then by all means let your class leader know. Class leader, you have a responsibility to let me know, right? If you're going to be late, you got to communicate, right? So while I don't mind if you get caught in traffic or you know, end up walking in late, don't particularly like it, especially if you don't let us know that you're coming in late, right? You have a responsibility to be here in this class, and this is for an instructor, right? So there are some students in other classes, hopefully not yours, that have just decided to skip the rest of the day and not show up for the rest of class, right? Doesn't happen in my class. So if you're supposed to be here, I expect you to be here, right? Is that fair? Now, what you can expect from me, despite my ridiculous schedule, is to be here on time in respect for your time, right? There's some days we might end early. I don't foresee a situation where we will end late, right? So I try to kind of keep things on time. I know sometimes you guys switch classes around based on what happens in the classes before you. Feel free to ask, but I schedule everything around this schedule, so chances are I may not have as much free time, right, to move my things around. But if I do, I will try to accommodate to give you guys time for testing, right? On some days you're going to have, especially Thursdays, you have a different test that is not ortho on Friday, okay? I will keep that in mind to give you maximum time to study for your next test. However, right, I prefer that you focus on this while you're here. That's the trade-off, right? If I walk around, which I do, I walk through the whole, all through the rows and up and down the aisle. If I see you studying something other than orthopedics while I'm in here teaching, to me that's just rude, right? If I see you on your tablets and, you know, playing Minecraft or whatever the heck else you guys play, that is not cool, right? And that goes for any instructor as well, right? It's just, these guys put a lot of time and effort into preparing these classes for you and to make sure we teach you the right things. The least you can do is pay attention, right? I will try to teach you everything that you need to know for your exam, right? If you listen well during the lectures, I think you will at least pass the exam. If you want 100, you're going to have to read some extra stuff. Okay, that's just fair. But everything that is on your exam, and then some, I will talk about it in class. Okay. The other thing too is there are pages in your on the website, right? The highlighted pages. Some of the information actually comes out of the highlighted pages. So take some time and at least browse through them. Okay. I do expect that you will ask questions. I will ask you questions, right? If you guys heard, I will ask you questions directly. It is not to put you on the spot or to make you look silly, but if you knew all of this stuff, you probably would not be in this class, right? So when we talk about these questions, to get you to think through the processes, so you're not just relying on a rote memorization, right? But you're thinking through and understanding these orthopedics, right? Finally, we're going to start off a little slowly, right? and we refer to some of these terms maybe in regular jargon. But as we pick up, right, by lecture 3, I'm going to start speaking to you as an educated, soon-to-be clinician, right, using all the anatomic terms and references that you guys have learned to this point. If that's too much, then you have to tell me. Otherwise, I'm just going to assume that you understand what I'm talking about. And you need to understand this stuff for the test. Okay? You guys are getting ready to be seniors in a few months. And when you get into the senior classroom, it's not the time for you to be trying to understand, what is anterior, posterior versus left and right, front and back, that kind of stuff. Okay? Is that fair enough? Okay. Do you have any questions about this? All right. Now, before I kick things off, don't get so serious about ortho. Ortho is a fun topic. I like it. We get passionate about it, which is why we do it. Okay? For you Army folks, and I can say the same thing for the Air Force as well, the vast majority of the patients you will see in your clinic are orthopedic related. The vast majority of the DNDI that you may see downrange, if you get so lucky to deploy, may be orthopedics related, right? So the physical exams, the labs, lectures, I want you to pay attention because it doesn't just help you on the pants, but it also helps you when you get to your clinics as well. Okay? All right. Questions or comments? Okay. So, let me make sure this works. Okay. So for block 1, right, lecture 1, these are the things that we're going to talk about. We'll do a quick anatomy review, right? I just want to prove that Major Davos taught you all the things that he was supposed to teach you, and just by your silence earlier, I am going to say that that is a true statement. We talk about Achilles tendons, ankle sprains, bunionettes, get a little bit into the diabetic foot, hallux rigidus, hallux valgus, and then we're going to end with interdigital neuroma, right? What I want you to take away from this slide, okay, is that in the bones of the foot, right, and we started from the ankle down, but we have to include a little bit of the distal tibia, right, and the fibula. The talus is a bone that bears a significant amount of weight, right, of body weight, right? And inferior to that sits the calcaneus, and so the talus articulates with the calcaneus, right? The joint between the tibia and the talus is called the what joint? Anybody? The joint between the tibia and the talus is called the what joint? The tibio-talar joint, right? So how about the joint between the talus and the navicular? The talo-navicular joint, right? And so as we get into speaking about these terms, that's where we're going to go, right? Guys tracking? Okay. And so in the bones of the foot and ankle, so we've got the tibia, we've got the fibula, right? In between the tibia and the fibula is what's called a syndesmosis, right? And sometimes when that syndesmosis gets ruptured, then you've got different problem altogether. We'll get into that when we get into ankle fractures. Okay? We talk about the midfoot, the forefoot, and the hindfoot. But what I want you to see in here on that left diagram, so we've got the navicular joints, we've got the cuneiforms. Sometimes folks refer to these as the first, second, and third cuneiforms, or you hear them referred to as the medial and the lateral cuneiforms, right? You have the metatarsals 1 through 5, 1 being the one that articulates with the hallux or the big toe, and 5 articulates with the bones of the small toe, right? And then you've got the phalanges, which are the bones of the toes. Just talked about the forefoot, the midfoot, and the hindfoot. This comes into play when we start discussing things like Charcot's arthropathy, right? Or the diabetic foot. The bones of the forefoot include the metatarsals and the phalanges, the bones of the midfoot, cuboid, and what are those 3 bones we talked about? Sternforms, right? And then, of course, we have the talus and the calcaneus that form the hindfoot. When we get into how the foot articulates for some of the arthropathies that affect the hindfoot, we talk about valgus and varus, right? And all of those are generally related to how the calcaneus sits, right, relative to the rest of the foot. Okay. Tendons connect what to what? There again. It says tendons connect bone to bone. Tendons connect muscle to bone. What connects bone to bone? Ligaments connect bone to bone. Right? So good. Okay. Some of the tendons that in this diagram, let me just go back 1 second. In this diagram, okay, is this a left foot or a right foot? It's a right foot, right? How can you tell? Because you're looking at the foot from what angle? Say again. So what if you were looking at this foot, if you're looking at a right foot from medial to lateral, or you're looking at a left foot from medial to lateral, could you tell the difference? Right? And so on the medial side of the foot, right, you've got this broad band ligament here called the deltoid ligament. This comes into play when we start talking ankle sprains, right? Pay attention to the plantar fascia that connects from the calcaneus to the rest of the foot. Here it looks like the plantar fascia actually stops right at that medial cuneiform. It actually does not, right? Because it extends all the way down under the foot, all the way to the metatarsals. Right. This interosseous membrane is the one that I just mentioned. We've got the anterior talofibular ligament, we've got the anterior tibiotalar ligament, and the anterior tibiofibular ligament, right? The name of the ligament tells you where it connects. So as you're looking at your radiologist report, and certainly when you're looking at your exam, or when discussing these things, pay attention to these. They sound the same, they almost look the same, but they're not the same ligaments. Okay? All right. So we talked about tendons connecting muscle to bone, right? All of the tendons that interact with the structures in the foot tend to cross the ankle joint. So the tendons that would effectively cause dorsiflexion, plantarflexion, which means you bring your foot up, bring your foot down, you move it from left to right. these tend to cross the ankle joint. So, by extension, right, the muscles that move the bones of the foot. You look nervous, I'm going to ask you. All right. The muscles that move the bones of the foot, where are they located? I promise you, this is not a trick question. Say again? Lower leg. They're located in the lower leg, right? You guys all tracking? All right. So when we start talking about how the foot moves, and we start talking injuries and how some of what happens or the impact of injuries to the lower leg affect the motion of the foot, that's what I want you guys, that's a thought process that you need to have. Don't just memorize where the ligaments and the tendons are. Understand their origins and their insertions so you can understand how they move and what they do, right? What is the inflammation of the tendon sheath called? Tendonitis, right? And we have this here because when we start talking tendonitis about the ankle, this is going to be very, very important, that perennial tendonitis. What I want you to take away from this slide is just how that network of tendons that affect dorsiflexion of the foot, right? And how they insert on the toes and the metatarsals. Okay? So if you notice that huge network of extensor tendons, right? There's an equally complex network of tendons on the bottom of the foot, okay, that are responsible for flexion of the foot, right? This tendon in particular, the EHL, right? When we get into the next lecture, I'll be looking at extension and flexion of the big toe. I won't test your anatomy, right, per se, in your exam. Maybe I might. You gotta remember the anatomy. But the point is that understand where these tendons lie, and then how they move the big toe, and how that is going to affect some of that pathology. And we'll get into that. So. Want to come on that later. Okay. Same for this. Now these tendons are not just floating around, right, within the tissue. These retinacular, right, the superior extensor retinaculum and the inferior extensor retinaculum actually hold these things in place. Before we get into that, let's talk the Achilles tendon for a second. The Achilles tendon is a confluence of which sets of muscles? What do you think? Gastroc, what else? That's good enough. Gastroc and the soleus, right? Which one is more superior? Or which one is deeper? The soleus is deeper, right? Okay. Now, the insertion of the Achilles tendon, right, on the calcaneus is extremely important for the motion of the foot. And when we get into some of the other pathology of the foot, it'll make a little more sense. But I want you to note that as the tendon inserts on the posterior superior aspect of the calcaneus, right? So you can have inflammation all along the length of this tendon. Okay. The junction between the muscle belly and the actual start of the tendon is called what? What's it called? Yeah, speak loud and proud, right? The musculotendinous junction, right? It is a weak point in that entire construct. And so a lot of times when you've got the start of Achilles tendonitis or some pathology that looks like Achilles tendonitis, it may not actually be in the structure of the tendon, it could be at the musculotendinous junction, right? And that is vastly different from what would normally be a calf strain, because if you have a calf strain, where is that pathology? Is it in the tendon or is it in the muscle belly itself? It's in the muscle belly itself, right? Okay. Questions on this? Is this good refresher? Am I going too slow? You guys got this already? Yes, I am going too slow? Excellent. Pick it up. Okay. Let's talk about how the foot moves about the talus and the navicular. So the primary motion of the foot, flexion and extension, dorsiflexion, plantar flexion, right? Extension of the foot is plantar flexion, flexion of the foot is dorsiflexion, right? Confuse it? All right, a picture is worth 1,000 words. These degrees of flexion and extension that you see here are just generalized numbers, right? You get folks that are more flexible than other folks, they have more motion about the foot and ankle than you would see here on this slide, okay? Or maybe less. As you get older and things begin to calcify, right, and you're not as flexible, then you find that your ankle motion decreases significantly. Right? Inversion and eversion. These are the other two that I need you guys to know. Okay? Easiest way to remember it, inversion means that the inside or the bottom of your foot is facing towards the midline of the body. Eversion is the opposite. Means that the bottom of your foot is facing towards the outside of the body, right? Away from the midline. Two more examples of how that would normally look as a pictorial diagram. We talked about the calcaneus, right, and how the calcaneus sits. When we start talking about valgus and varus and equinus, I want you to keep this in mind, right, and we may refer back to it so you guys have a better understanding. Okay, pronation and supination of the foot. Now I'm sure in upper extremity you guys talked about pronation and supination of the hand, yes? But as the forearm pronates and supinates, you have more motion because of the way that the radial head rotates, right? You guys tracking? But you don't have that situation here in the foot because you have long bones in the upper extremity, you don't have that in the foot, right? And so when we talk about pronation, what you find is that pronation is a combination of movements, right? There is a little bit of plantar flexion and a little bit of eversion in a pronated foot. And likewise, in supination, there's a little bit of inversion and a little bit of dorsiflexion. Okay? You don't see it in here, but when you get home, you take shoes off, take your socks off, hopefully you wash your feet, and then you allow someone to just observe your foot as you pronate and supinate. You'll realize that it is a combination of movements, right? If the foot goes beyond its normal range of pronation and supination, then that becomes a problem, right? And so in most cases, when we start talking about clubfoot and other different pathologies in the foot, you realize that over-supination and over-pronation becomes a huge issue, right? Start causing pain, start reducing function, and therefore, that's when the patients come see you. Okay? The normal foot, the calcaneus, or the back of the calcaneus, is normally aligned with the long axis of the tibia, right? If it's supinated, then you have that inward facing angle, right? Which means that the apex of the angle is towards the outside of the foot. And as you begin to over-supinate, then that angle increases, right? Any questions about pronation, supination? Dorsiflexion, plantar flexion. Okay, so once you work up a patient, right, you may get some radiographic studies. How do you know? Do we have any X-ray techs in here? Raise your hand, be proud. Usually have at least one. Huh?
They're still on the cover.
They're still on the cover, huh? Yeah. You guys should be proud to do this. Okay. Your radiology techs, you don't have to tell them, you tell them the view that you want and they position the patients to get the view that you want. These guys are very good. If you get a good one, you're phenomenal, right? If you get a bad one, you're in trouble. Because they send you things and you have to have them repeated. An AP view, right, there is going to be a little bit of an overlap between the tibia and the fibula, right? If you notice, if you get a view and there is a big space between the tibia and the fibula, that is not a true AP view, right? And switch to a lateral view, you'll notice that there will be some superimposing of the fibula on the distal or the posterior third of the tibia. So you know it's a true lateral. Okay. And you have a clearer view of the talus on the calcaneus. Okay? This space right here. When you get an oblique view, which you may have to order in some cases. If you order a 3 view of the foot, this is what you're going to get. Then you have a clear view of this entire joint space, right? So you see how the tibia articulates with the navicular and the fibula articulates with the navicular, right? I'm sorry, with the talus, okay? So this tibio-talar joint and the fibulo-talar joint, okay? Normally it's evenly spaced in a lot of cases, right? And that's called a mortise view because you have a clear view of that joint. When we get into the different fractures, then we talk more about this. Okay. Any questions on this anatomy review? So let's talk about Achilles tendon tears. We talked about how the Achilles tendon articulates or inserts on the posterior superior aspect of the calcaneus. Patients that present to you with what looks like an Achilles tendon tear, they usually present in a very textbook manner, right? It's usually some 40 to 50-year-old guy who decides to play a game of pickup basketball with a bunch of young dudes and swears that one of them kicked him at the back of his leg or hit him with a baseball bat. Okay? Normally, these patients, they're unable to walk or have difficulty walking or walk with significant or with the need for assistance. And Usually there is immediate swelling, maybe some bruising. And if it's a complete tear, then you have a palpable defect where the Achilles tendon should be. The weakest point in the Achilles tendon where this typically happens is about 5 to 7 centimeters above its insertion on the calcaneus. In a lot of cases, there is or could be a partial tear, in which case you've got some disruption of the actual tendon, and sometimes you get this in coordination with a calf strain as well. Many patients that sustain Achilles tendon ruptures have had some sort of a partial tear or Achilles tendonitis in the past. And so, one easy way, right, to assess these patients is to do what is called the Thompson test. Did you guys cover this already? No? Okay. Now, you will see in your practice, you will see some folks have the patient standing or sitting on the bed, and they will squeeze the calf and try to elicit a response. The posture that you see here with the patient lying face down or in the prone position with his foot hanging off the side of the bed is puts the Achilles tendon in its most relaxed position. That's the proper way you should do the Thompson test. Okay? Now, if you squeeze the calf, right, if you activate the calf in a patient with an intact tendon, what should happen to the foot? It should go into plantar flexion, right? Much like if you were walking and you engage the calf, right? Your foot should go into plantar flexion, allowing you to do a heel raise. Yes? Okay. If that mechanism is disrupted, then the foot cannot go into plantar flexion. And that's a positive test, right? Again, a positive test is that the foot does not go into plantar flexion. A negative test is if the foot actually moves into plantar flexion. If a patient presents to you within weeks after the injury, then that test becomes less and less reliable, right? Because immediately post-injury, what you have is consolidation of tissue, you've got some swelling, and then the body actually tries to start healing this thing, right? So it starts developing consolidation of blood and other interstitial fluid at the site of injury. And so your Thompson test may not be as reliable, okay? So you want them in as soon as possible after injury. If you looked at this on an ultrasound, and hopefully, I think we have ultrasound for your lab, you will get to actually see this. So we need some volunteers to donate their Achilles tendon to science, okay? And what you'll see is some hypoechoic areas in where the structure of the tendon should be. You can get a plain film. Plain films actually show you the structure of the tendon itself. However, if you want a more reliable diagnostic study, then an MRI is the best friend. Okay. But with the introduction of ultrasound in the emergency department and into primary care right now, it's a cheap and reliable way of actually getting after diagnosing an Achilles tendon. So how do we treat these things? Well, it all depends, right? If you want to go with non-operative management, what you want to do is you want to make sure that both ends of the tendon are as closely approximated as possible, right? So I want you to think about this in the sense of you've got a band that was ruptured, and in most cases, as longer it stays, then the more that tendon retracts, right? And so if the patient comes to see you maybe 2 weeks post-injury, that tendon may be too retracted even to put the foot back in plantar flexion to get them closely enough approximated so that you can apply non-operative management. Okay? If the tendons are too far apart, even if you plantar flex the foot, you may not get that tendon to retract far enough with the two ends. Okay? And so the further out they are, then more than likely they'll be more open to operative management. If you're going to treat them non-operatively in a cast, splint, in most cases in a cam walker, then you want to make sure that foot is in plantar flexion. And the way we do that, you put them in the cast, put them with heel raises or heel pads that will elevate the heel and force the foot into plantar flexion. Okay? For the vast majority of injuries that we will talk about here in block 4, rest, ice, compression, NSAIDs is going to be your initial management. Does it make sense? And so, whenever patients present you with these injuries, your first bet is, number 1, stop the offending activity. So, the rest portion of it is not to go home and rest, it's to rest from offending activity. Okay? We talk about the application of ice. We just spent 2 minutes talking about how do you apply ice to a newly injured extremity. Okay? Number 1, never put ice on a bare extremity. Yes? Now, if you're old school, right, you will have some frozen peas and frozen mixed vegetables in your freezer, right? Because you're always breaking things. Don't ask me how I know. Right? That's the thing. And so you put a towel down, cover the bare skin, and then you apply either ice, crushed ice. In some cases, crushed ice with some water, and then you have a better effect that way. All right, you should apply ice to the area until it gets cold and it starts feeling a bit numb. Then you need to remove the ice, right, so you don't damage the skin. Okay, and that's the level of education which we give patients. The activity modifications, right? So you stop the offending activity. In all population, then they may need a physical profile of some sort, and then I give them some NSAIDs. Okay? Your patients, especially, and some of you probably have done this, why is it that every time I injure something and I go see the doctor or the PA, they give me ibuprofen? Right? Because ibuprofen is an excellent medication for musculoskeletal injury. If your car runs out of gas, you don't go put oil in it, do you? You fill it with fuel, because that's what works, right? Same thing with any of the NSAIDs. Okay? Tylenol is not an NSAID. What is Tylenol? What? It's an antipyretic, but for our purposes here, right? It's an analgesic, right? And so, if a patient comes to see you and they're on naproxen and they're taking ibuprofen, what's your counsel for them? Stop one or the other, right? They both get metabolized and excreted through kidneys. God forbid they have kidney problems, don't drink enough water, which none of us do, right? And so you set them up for failure if you don't, okay? So, can you give Tylenol and ibuprofen together? Why? One is metabolized in the liver and the other one is metabolized in the kidneys. Okay? If I don't want to put a patient on narcotics, right? Even post-op patients, so usually 800 of Tylenol and a 800 of ibuprofen and a gram of Tylenol tends to do the trick. 6 to 8 hours, and I can keep them off narcotics. There is a max dose for Tylenol, though. You gotta be careful. Okay. So when the patients are in a cam walker, right, which is that big black boot that you see here, the best way to ensure that that the patient is doing well is to put the heel lifts, right, keep them off of it with some crutches, and then you visit them or they come back to see you every 1 or 2 weeks. If that fails, or it takes them too long to present to your clinic, then you refer them to Ortho for operating management. Okay? What's the difference between surgical and non-surgical management of Achilles tendon tears? Well, say again? There's not a whole lot of difference, except we tend to have a higher rate of re-rupture with non-operative management. But generally speaking, outside of that, the outcome is the same. And so some patients will opt for surgery, some patients will opt for non-operative management. Ankle sprains. Yes.
On average, how long do you expect, like, your normal patients to start going in your experience? How long do you stay before we get that blood collected?
Yeah, so we start with 6 weeks, right? Now, it's a very good question. In the past, and I'm fairly old school, I think. I'm supposed to agree with that, but I got you. We would keep them in the cam boot, no activity, no physical therapy, because we want to preserve the integrity of the healing process, right? Now we're moving into physical therapy earlier rather than later, right? Some new articles that have come out, even for ankle sprains, immobilization is very short, like we're talking days, and then they start moving them so that we can get them moving rather quickly. Right? The longer you keep them immobilized, more stiffness develops. Right? We used to rely on physical therapy to reverse the stiffness. Now we're looking at how can we prevent the stiffness and promote healing at the same time. Excellent question. Any other questions on Achilles tendon? We start talking ankle sprains. I'm sure you guys have covered this in some other classes, right? If you have an inversion injury, the most commonly ruptured tendons are the ATFL and potentially the CFL. Right? The anterior talofibular ligament and the calcaneofibular ligament. It all depends on the degree of ankle sprain. So it depends on how much you twisted your ankle. Most times you have folks that stepped on a rock, stepped off a curb, twisted the ankle with the apex, right, of the foot pointed towards the outside, right? Talk about that inversion injury, rupturing these two tendons. Now, in very severe ankle sprains, in which the syndesmosis is also affected, right? Severe ankle sprains in which the syndesmosis is also affected, that puts that injury into a whole different category. Okay? Most times you see these, it's because there is an eversion injury in which the deltoid ligament is affected. If you have an ankle sprain and there is medial-sided tenderness, right? Medial-sided tenderness, then you have to have a high index of suspicion that there may be other injuries involved. We're going to touch on that in a second. Eversion injuries are way less common than inversion injuries, but they do happen. So, Patients that sustain these injuries, they may or may not tear apart. There may be some swelling. The degree of ankle sprain is all dependent on the mechanism of injury and the force that's applied to the ankle. Okay? Some may or may not be able to bear weight. The one thing that you have to remember is that if you don't treat it, then it leads to chronic instability of the ankle. Repeated ankle sprains also lead to chronic instability, right? Chronic instability leads to increased pain and eventually the development of secondary osteoarthritis in the ankle. Okay. There are ways that we can treat those surgically, but if you can avoid it, then why? So with the introduction of H2F and a lot of the new exercises that the Army is developing, we're hoping to prevent a lot of these. Okay? So when patients present, right, in addition to pain at the location of the injury, in some cases, if the ankle is grossly swollen, you cannot do a proper physical exam. And so, if you cannot complete the physical exam, it is absolutely appropriate to immobilize the ankle, give him some instructions to rest it, elevate it, apply ice to it, come back in a day or two, and then complete your exam, right? We talk about getting x-rays and the Ottawa ankle grooves and all that good stuff. But looking at the initial presentation of some of these injuries, you have to understand that not all ankle sprains present the same way, and not all of them will be amenable to non-operative management. Okay? So, during your I think I mentioned it during the last lab, my method, right, for dealing with musculoskeletal injuries, right, on watch the way the patient actually ambulates, how they walk, right, that tells me a lot. He comes in on crutches, that tells me that he can't bear weight, right? Some of them may be faking, but generally speaking, right? Now, then I want to look at the extremity. Is it swollen? Is it deformed? Is there a lot of ecchymosis, right? Then I get into palpating. That's always why it's important for you to understand the bony structures beneath the skin, so you know what you're palpating. Understand where the ligaments lie. If you don't know where the ATFL is, it's very difficult for you to understand the mechanism of injury, right? Or the extent of his injuries. You want to rule out fractures of lateral or medial malleoli, right? If you know which tendons attach to which part of the malleolus, it's easier for you to understand what you're palpating. If you know where the ATFL is and where the CFL actually inserts on the lateral malleolus, then it's easier for you to understand where and the extent of his injuries based on your palpation and his pain level. Okay? If you feel crepitus at all, that's probably a sign that something is broken. Probably, likely, right? If you palpate a normal ankle, you should hear no crepitus. Should. May happen though. It's an old guy, an old lady, right? Now, there's medial-sided tenderness. I would highly encourage you to do the syndesmosis squeeze, because in a lot of cases that means that the syndesmosis is also ruptured. You can have some syndesmosis injury without a medial-sided eversion ankle sprain, but generally speaking, that's what you get. And in addition to that, I want you to remember that you also want to palpate the proximal fibula as well. Okay, we cover that in fractures, but if you've got a deltoid ligament injury, right, so he's got medial-sided tenderness, he's got a positive syndesmosis squeeze, and he's got palpation or tenderness at the proximal fibula. What do you suspect? Messing of injury. You are released. All right. So, now, when we get into fractures, we'll dig a little deeper into the different type of fractures, right? But that is a big deal, and if he's got a Mason nerve injury, then that's an immediate referral to orthopedics. Okay. Take time. Make sure you guys to settle down. Who's missing? Look to your left, look to your right. Your buddy's not here. Don't cover for them. They'll get you in trouble. Or you should cover for them. The teams do. You want to add something?
Yes, sir. Can you guys hear me? Okay, so I know what you guys are all thinking. I've had like 3 people approach me already. So I have a question for you guys, since you don't like to ask questions, right? What is the difference between inversion and eversion, internal rotation and external rotation, and supination and pronation of the foot? Don't throw in dorsiflexion flexion. That's easy. All right. Mumble. Because this is what comes up, right? So I want to be sure we're on the same page before we get to lab, okay? So this is how you're going to remember it. Inversion, eversion, like Colonel Sylvester said, is a rotation involving the sole of the foot. External rotation is a rotation on the log axis that involves the entire foot, not just the sole. Okay? So everybody take a second. Oh, she's eating. Put down your eating, right? And evert your ankle, and then internally rotate your foot. You can? Okay, she's going to do it. Because if you understand it today, right, then you understand when you're doing the physical exams, because there are physical exams, right? Tailor tilt tests, things like that, they require you to do certain motions, okay? So if you don't understand this concept, you can't move on to the exam because you don't understand what the motion is you're trying to accomplish, okay? And then, what does that lead? Supination, pronation. So supination, pronation is an alignment thing. Like that picture that we showed you, supination, pronation involves alignment. Okay? So it is a dynamic thing when you're watching somebody run, but overall, when you have somebody stand, and they're standing in an overpronated position, that's something you're observing. You're not necessarily doing any kind of eversion, inversion, or internal, external rotation. Are we good? I guarantee somebody's not good. Okay, because I know, right? And you're not going to ask the question, find me when I'm trying to go to the bathroom or when I'm trying to eat my lunch finally. That's what you guys do. But make sure you guys understand those things, because when we get to lab, right, you guys know that we added a whole other lab for foot and ankle, right? And there's also splinting. Don't be nervous. Okay? Good to go? Any questions? Of course not.
Not to mention when you get to fractures, you're going to know this stuff. All right. Yes.
Would it be safe to say that supinated versus pronated would be on a fully weight-bearing foot versus the other ones could be free floating, like no weight bearing?
That is not safe to say.
Okay. So like you get the two.
I see where you're going with this.
You get 2 joint movements with the
Yes.
planted foot better than like potentially.
But
just
you could still pronate and supinate the foot
Okay.
without the foot being planted, right? Or in weight-bearing styles. Actually, you see, you get a better appreciation for pronation and supination of the foot if you're hanging the foot off. And we'll cover it in exams, but good thought though. Now, the stress on the ligaments on the lateral and medial side of the ankle, that will not come into play unless you're in weight bearing, right? So unless someone is actually talking on your foot, right, then it's almost impossible for you to injure your ankle, just a healthy ankle, by just actively pronating supinating foot. Muscles just don't work that way. Any more questions on this? Okay. So we talked about looking at the presentation of an ankle sprain. There are some areas that I really want you to hone in and make sure that you assess. So we talked about the lateral malleolus, right? For inversion injuries. We talked about the medial malleolus for eversion injuries. If you have a medial malfracture, you want to also make sure that you assess the syndesmosis and the proximal fibula as well for Mason nerve injury. Okay. In cases where you have a lateral sided injury, also take some time to assess the base of the fifth metatarsal, right? Because there could be an avulsion fracture at the base of the fifth, and in which case you have to address these as well. Okay? When we get into fractures, we talk about fractures in zone 1, zone 2, and zone 3 of the fifth metatarsal. All of them are treated differently. Okay? But we save that discussion for lectures. When you start looking at range of motion of the foot, then you take the foot into the different ranges of motion that we just talked about. So internal rotation, external rotation, plantar flexion, dorsiflexion, right? You go with active range of motion first, then passive range of motion. In most cases, range of motion is limited by pain. Okay? It's not that there is no range of motion of the extremity. It's just that the patients don't want to move it because it hurts, right? So when you document, there is range of motion limited by pain, right? Not no range of motion. Makes sense? That's more accurate. Radiographs of the foot. So how do you determine when you should or should not get radiographs? So we talked about the Ottawa ankle rules, right? In which case, you ensure that the patient can ambulate, right? And then you palpate at different areas based on whether or not you're looking at injuries of the foot or the ankle. And then you determine whether or not you want to send them for x-rays, okay? That is a good way to rule out if there is a fracture or not, or it raises your index of suspicion of a fracture, in which case you determine whether you should put them in a splint or cast, or whether you should just have them rise, put a soft bandage over it, and then limit the motion. Okay. Again, with their initial presentation, and based on the severity of the injuries, rest, ice, elevation, some NSAIDs, and then you take it from there. Okay, Ottawa ankle rules. If you're looking at the ankle, first you want to determine if they have pain at the lateral or medial malleoli. Okay, that's the first step. Then you look for tenderness at the posterior edge of the malleolus. So you just simply palpate at the back of the lateral and or medial malleolus. Okay? If they are tender, then you have them walk on the ankle, right, on the extremity. General rule of thumb is, can they bear weight and take 4 steps? Okay? If you've done this long enough, then you can tell, right? And in some cases, I don't even wait for them to take 4 steps. They can bear weight on the ankle. It doesn't matter if they can take 4 steps or not. I may send them to get an x-ray. In other cases, based on where they tender and based on the level of swelling, I may not put them in for x-rays. If you're looking at the foot, then you look for pain in the area of the midfoot. And then we talked about this a few minutes during the anatomy review. Look for tenderness at the base of the fifth, tenderness at the navicular bone, and again, see if they can weight bear. Okay? These are just general guidelines for whether or not you need to send a patient for x-rays. What we found is that if you apply these rules, then you don't expose your patients to unnecessary radiation, essentially. Prior to these, if there's pain in the foot or in the ankle, we would simply send them to get an x-ray. because we did not trust our clinical judgment. The way we teach you now, your clinical judgment outweighs some of what. This is just icing on the cake, right? It's not, you don't treat your x-rays, you don't diagnose by x-rays. You diagnose based on your clinical judgment, patient presentation, and use this to help with your clinical assessment and treatment. See some of you guys writing in 2 seconds. This is in your slides, by the way. It's not?
Up the side.
It's missing the description rules.
These are my teaching slides. Okay. Give you a second to write. Oh, you guys were very like, it is not. Scared the hell out of me. I do promise to be as fair as possible, because my Catholic guilt gets to me if I do things that I think is unfair. So, 9 times out of 10, if it's not in a slide that's in your slide deck, may not be on your test. However, this is important for you to know, right? Because I may refer to it, but you should know, since we covered it in class, how to apply the other angle. Okay. All right. So we talked about treatment. We talked about assessment. We talked about treatment. We talked about presentation. The goal of non-operative treatment is to prevent chronic pain and instability. Right? Remember, I mentioned at the very beginning, if you continue to sprain your ankle and not get it treated or get it inappropriately treated, then you develop instability, you develop laxity, and further on you develop secondary osteoarthritis, right, at the joints. Physical therapy may initiate some of these phases of treatment, right? Some of it starts with you, because you have to do that initial step to get the patient back functional and back to activity. Okay? And again, it's the NSAIDs, the rest, ice, elevation, stay away from offending activity. And then you assess range of motion, proprioception, and get them back to normal functioning. That's where physical therapy comes in. Okay? Any physical therapy text me. No? They're on the cover. I don't know what's going on. You guys are scared to be proud, right? Okay. But, and I know, I think you're a strength coach, right? Okay. Yeah, he is. Close. Yeah, he is. It's calling you out, man. Okay, so, if you're coming from the Fort Bragg or Fort Stewart area, and some of these other places, the strength coaches are doing amazing work out there, right? So when you get to your units, if you don't have these guys as part of your H2F PT thing, then you might start requesting it. Okay. So it takes about 4 to 6 weeks for all that rehab and to get these soldiers back or these patients back to regular function. But it's gradual, right? And so a patient that's been off running because of an ankle sprain for 2 to 3 weeks, you don't get them back into a 4-mile run at the start of week 5, right? So gradual return to duty, gradual return to activity. When all of that fails, or if there's chronic instability, then you can consider that a failure of non-operative management. So, an indication for surgery for any of the musculoskeletal conditions that we talk about is always failure of non-operative management. Okay? There are some things that surgery can and cannot fix, but in a lot of cases, most cases, If the patient fails non-operative management, that's an indication for referral to surgery. I'm not going to go into detail how we do these, but ankle reconstruction is called a brushstroke procedure, where we tighten things up and cut ligaments and tie them together and put screws into the bones just to get it nice and stable. And that has seemed to work very well. We continue to do those, right? So a patient with a loose ankle that is, exposed to or continues to have chronic instability, your counsel to them is not like, hey man, what you got is what you got, okay? Because there are ways that we can continue to fix these things. Now, earlier on we talked about how long do you immobilize, right? And so if you keep them in a boot or in a cast or in a splint or in a brace for too long, right, that leads to more and higher degrees of stiffness. So you got to make sure that you take that into consideration as part of your treatment plan. Questions about ankle sprains? Very benign, but these ankle sprains will eat up a significant amount of your time for patients on active duty or young kids that are just getting into sports, okay? or people that try to do young people's stuff. Some of us don't learn. Okay, let's talk about the bunionette. We talked bunionette now, we'll talk about the bunions later on. One is on the lateral side of the foot, the other one is on the medial side of the foot. The bunionette is associated with the fifth metatarsal. The bunion is associated with the first metatarsal. Okay? When we get to speaking about the bunion, you'll notice that it is almost a mirror image of what we're going to talk about right now. Okay. So, this is also called the Taylor's bunion. Okay? And it's a lateral deformity of that fifth metatarsal. So you've got prominence of the metatarsal head, right? Which other bone does the metatarsal head articulate with? Did you say? The phalanges, right? So the fifth metatarsal head articulates with which of the phalanges? Which one? Proximal of which toe? Yes, pinky toe, right? This is the opposite for what happens in the case of a bunion. Do not confuse the bunionette with the bunion. Okay? So you've got prominence and lateral deviation of the fifth metatarsal. Okay? And because it constantly rubs against the shoe, then you may have a corn or a callus developing over that prominence. As you can see in this picture on the far right, you can actually see that deviation, right, on your physical exam. And the same for the bunion as well. Now, we get these in folks that wear very narrow or pointy-toe shoes, right? Men or women who wear shoes with high heels and pointy toes are very prone to this. Okay. Most times, patients will present with pain that increases when they're wearing the shoes, and sometimes relieved when they take the shoes off. It is beyond me, and your patients will present, they will come to you wearing high heels, foot is painful as heck, right? And some of my patients have refused, adamantly refused, right, to not wear high heels. The best fix for this is shoe modification, right? So if pointy toe shoes are the ones that's causing the problem, you put them in a shoe with a wider toe box. And for a lot of the toe problems we talk about, right, that is the most appropriate treatment is to put them in a shoe with a wider toe box. I will prepare you now that your patients will fight you when you tell them that you're going to put them in an ugly shoe. They do not like it. But it is what it is. When you take your plain films, here's a plug. Unless otherwise indicated, if you're taking x-rays of the foot, you want to take weight-bearing x-rays. Okay? So if you find yourself in a situation asking whether or not you should take a weight-bearing x-ray of the foot or a non-weight-bearing x-ray of the foot, I want you to default taking weight-bearing x-rays. Okay? Unless it's absolutely indicated, as in the patient has, stepped on a rock, stepped on a nail, and has some foreign body in the foot, something like that, right? Otherwise, weight-bearing x-rays of the foot, all times. Okay, so we talk about lateral deviation of the fifth metatarsal shaft. One big difference with these is that there's no compromise of the joint space. We talk about some other conditions in which the joint space is compromised, right? You've got osteophytes, and you've got outgrowth, and you've got erosions. This is not one of them. This is just merely a condition that is forced because of the way that the narrow shoebox impacts the foot. Okay? Again, treatment, rest, ice, elevation, NSAIDs, and you change the offending activity, in which case you give them a shoe with a wider shoebox. Okay? There are some things you can do, like using orthotics like the metatarsal pads that will help offload, right, the metatarsal head. However, if you prescribe a patient some orthotic pads and you keep them in a narrow shoe, okay, that does not help. Actually makes the thing worse, right? Because now you've narrowed the space with that other pad. Okay. So again, the cure for this, or the treatment for this, is an ugly shoe. Right? When all else fails, right? So when that non-operative management fails, then they come to surgery, right? They refer them to orthopedics. And what we do is either what is called an osteotomy. So we would, picture here. So we would actually cut the bone, right? And then reshape it so that it is now nice and straight and restore the normal anatomy of the foot. Podiatry does a lot of these as well. Right? So I will say a lot of things here refer to ortho, but if it's foot problems, understand if I forget that you also refer to podiatry. Okay, so the outcome of treatment, right, is not necessarily to make the foot better, but we also do that as part of the treatment, right? But it's to correct all the painful issues. Diabetic foot. Any questions on the bunny net? Okay, have you guys learned about diabetes?
Yes.
All right, so we're not going to go into the pathogenesis of, glucose control, etc., etc. But I want you to understand that poor glucose control eventually leads to peripheral neuropathy, and that is what causes much of the impacts to the diabetic foot. Okay? So patients who've got peripheral neuropathy and have absolutely poor glucose control, they will present with either painful ulcers, swelling of the foot, skin ulcerations, lack of sensation, and a whole host of other issues. Okay? Generally speaking, if you've got a patient who is obese, right, swollen foot, and just has weird sensation in the foot, then you have to increase your suspicion for diabetic neuropathy. Okay. All right. So, I think the last I saw was like 40 million people in the U.S. have either type 1 or type 2 diabetes. Very common. And again, all the different conditions that are associated with these, with the skin ulcerations and infection, we'll talk about these in a second. Okay. Vascular insufficiency is what really accounts for most of the problems that you will see with the diabetic foot. Okay. Because you've got vascular insufficiency, it leads to destruction of not just tissue, but destruction of nerve cells, starvation for oxygen, and then you've got all kinds of issues. Okay? So, all of this leads to that loss of protective sensation. So if you're walking around and you kick something, you know that you kick something. In the diabetic, because they can't feel, they continue to kick things. Have you ever stubbed your toe and then realized that after you stub your toe, you just keep kicking everything, right? That's because now you're hyper aware, not the incident is any greater, right? You're just more hyper aware that you're bumping into things. These diabetics do not. Okay. Now, as a young PA, it's very important, you shouldn't judge any patient. Okay? It's very important that you don't judge these patients. When we start talking diabetic foot, they can get very macerated. The patients have no idea what to do, especially if they don't know what's going on. Okay? So it's very important for you to have some empathy, because you will be the gateway for some of these conditions. They may just come see you, or someone may refer them to you just because. And we have quite a few on active duty, right, that discover they're diabetics after they've seen the PAs at the aid stations. And then we talk about Charcot's arthropathy in a second. All right, so sometimes these patients have no symptoms at all, right? Or they don't know what symptoms that they're reporting. But what you may see is a breakdown in the skin. You may have a painless ulcer. If a patient presents to you with a painless ulcer, then that should raise your suspicion, especially in our population, for uncontrolled diabetes. Okay? In cases where those ulcers are very deep, so this just the bottom picture here shows the progression to treatment, right? We'll get into that in a second. So it started off like this. Proper treatment gives you what's on the far right. Okay? What you see on the far left is a deeper wound, painless. If it gets into the bone, or if you can see the bone, or if you can palpate the bone, then that should raise your suspicion for what exactly? Osteomyelitis. Okay? In cases where we cannot control this osteomyelitis, then that leads to amputation. An amputation of a diabetic foot is a significant traumatic event for that patient. Okay? As the condition progresses, then you run into what is called a Charcot's foot, which is a collapse of the midfoot. And as you can see in this picture, this is a normal foot on the left side. And right here, at the midfoot, at the Charcot's joint, there is that collapse, right? Ligaments between those bones simply weaken, foot collapses. Now, when the foot collapses, what you have is increased pressure points where the talus and the navicular actually contact the base of the foot. So, part of your physical exam, right, in addition to what you mentioned, so you look at it, check the range of motion, you palpate, right? Document your findings. And then we introduce something called the monofilament test. Okay? These monofilaments usually come in a little packet, right? And in many cases, you may have more than one of them, right, in the pack. But you want to pick out your 10-gram monofilament, and the way you do this, for each of the different sites, I'm going to talk about these in a second. The way you do this is that you press that monofilament against the skin until it actually bends, okay, and you document your findings. If they can't feel, it's a positive finding. Okay. Now, you look at the top picture. Okay. You place it against the foot, press it till the filament bends, right, in the middle picture, and then you release. There are 9 points for a complete monofilament test of the diabetic foot. Some literature will actually tell you 7. I learned it as 9, so I'm teaching you the 9 points. Okay? So that's at the base of the 1st, 3rd, and 5th toes. 1st, 3rd, and 5th metatarsals, right here at the midfoot, and then at the calcaneus, right, all on the bottom of the foot. So for all intents and purposes, that is what I want you to learn as the proper procedure for doing a monofilament testing. Now, if you end up probing a wound, right, and if you probe and you hit bone, again, that's an indication and a suspicion for osteomyelitis. It does not mean that because you probe and you hit bone that that patient has osteomyelitis, but you should suspect it, right? In cases where you have diabetic ulcers, the area around the ulcer or the entire foot may be swollen, may be erythematous. Okay? It may look like cellulitis. So how do you differentiate whether or not you've got a Charcot's foot versus just a cellulitic foot? Elevate it, right? You elevate it. Now, if you've ever seen an infected anything, the redness does not go away with elevation, correct? That's what you tell. In a Charcot's foot, the redness subsides. Okay. You guys all tracking? So you can take plain films. It will show you the collapse of the midfoot. If you're looking for the extent of a bone involvement, as in osteomyelitis or deep abscess, then you need to do an MRI. Okay? You can try nuclear medicine scans, right? The TAG white blood cell scan is not the same as bone scan or Tech 99 scan, right? You guys talk about that in radiology? Yes or no? Yes. Right, I'm going to find Major Passion and find out why he didn't teach you these things. I'm telling you said, right? So, with the Tech 99 scan, that's your normal bone scan, right? In the TAG white blood cell scan, what you do is you draw the patient's blood, you tag the white blood cells with a radioactive material, and then you introduce it into the body. And the idea is that white blood cells will be attracted to the site of injury, because that's what white blood cells do. And then you take some pictures. I am grossly oversimplifying this. However, that's the basic premise. Okay? You go into the science of it, but I don't think you want us to do it. You want to come see me afterwards. Okay. In the case of osteomyelitis, it's going to be hot because there's inflammation at that site. In the case of a Charcot's foot, it is not. Okay? So just remember that when there is inflammation, right, as in osteomyelitis, either the tagged white blood cell scan or even the bone scan will be hot at that site. Yes? But whereas the bone scan is very sensitive, it's not very specific. Okay? So you'll hear me say over and over as we go on through the test, through the course. If I am walking and I bump my knee into this thing and I take a bone scan right afterwards, it is probably going to show up hot because it just shows that there is some activity. Of course, again, oversimplifying. But the point is that bone scan will catch anything that is remotely active, right? But it doesn't tell you what's happening there. The tagged white blood cell scan, because it's white blood cells gravitating to a site of injury, right? Or I'm sorry, a site of infection, then it's more specific for these infectious processes. That's a big difference. Questions about that? Okay. So the goal of treatment for the diabetic foot, right, is not necessarily, well, number one, you want to cure whatever it is, right? But you want to prevent the patient from getting to that point in the first place. And so when you suspect a patient has diabetes, or if they have issues with their feet, then you want to make sure that you teach them proper foot washing. Okay? There are diabetic clinics that do these for more advanced patients. It's very easy. You wash your foot, you dry your foot, right? If you're the one who's doing the washing and drying, then you want to palpate the area just to make sure that you don't feel any lumps or bumps. Okay? Look between the toes, because diabetic patients are very prone to fungal infections, and therefore a lot of them have athlete's foot, or what looks like athlete's foot, right? And so check in between the toes. And then you do all of your exams to make sure that they have decent blood flow. Okay? So serum glucose control is the hallmark of trying to stem the tide of this thing. Okay? When all of that fails, then of course you have to refer them to orthopedics for further management. Okay. Now, in patients with a Charcot's foot or even diabetic foot, if they have a superficial ulcer, you can still put them in a total contact cast. Okay? It's different from the cast that we're going to do downstairs during casting. Take a question I was asked during the last class is, if a patient has issues with their feet and they have superficial ulcers, why would you put them in a cast? Okay? Is the answer. Because the total contact cast, what it's designed to do is to distribute weight, right, across the length of the foot. It's a very special cast. It's built in a specific way to offload any of the pressure points. Okay? And so the things that we will need, or if you've seen anyone do casting, it's a different set of material that we use for the total contact cast. And so the patient, it allows the patient to not have any pressure points while they're walking. Actually pretty cool. And sometimes we'll cut windows into the cast so that you can come in and do wound care without taking up the entire cast. However, when I put these on in the past, then we will bring them back in about a week and assess the foot to make sure I didn't create any pressure points when I put the cast on, right? And make sure it's working okay. And then if not, some people reassess in a week, in 2 weeks, but they continue to do that for sometimes up to 6 weeks. And a gentleman who was being casted, I think, about 6 months. Ridiculous. His foot was back. But he never kept from eating chocolate and ice cream and cake. I don't blame him. Stuff is. Okay. Other cases, right? Make sure they got a large shoebox, right? Anything to offload the foot. Operating management, when non-operating management fails, is drainage of abscesses to debride the osteomyelitis. Whether they develop dry or wet gangrene, doesn't matter. If we cannot control an infection, then the next step is amputation. An amputation can go, can be amputation of just, a toe, can be an amputation of a ray, right? And the ray is simply, the entire toe plus the metatarsal, right? So you take the phalanges and the metatarsal. Right? Questions on the dietetic foot? When you review all of this, take some time to understand not just the process, but why we do the things that we do in caring for the patient with the diabetic foot. And then link that back to your diabetes lectures so you understand why the foot is doing what it's doing. Okay? When you refer, right? Patient with some pain, swelling, a non-healing ulcer, or unexplained pain in a patient with history of diabetes. Hallux rigidus, as the name suggests, there is some rigidity at the MTP, at the hallux MTP, right? If you look at that picture on the right side, you see normal flexion and extension of the big toe, right? Hallux rigidus, the picture on the very bottom, shows that you cannot flex the toe, okay? It's the second most common foot problem. And it is usually caused by arthritis at that first MTP, right? The tarsophalangeal joint. Remember I mentioned earlier on, when you have arthritis, what do you have? You've got a bunch of bone spurs, you've got erosion of the joint space, right? You've got inflammation that causes that erosion, and therefore you've got deposit of extra bone in that section, and limiting your ability to flex and extend the joint. Okay. Most patients that present to you with these, they will say, hey, when I step off, right, as the step off part of your gait, it's very painful, my toe hurts a lot. And on assessment, then you realize that they have limited range of motion in the toe. Okay. So, the hallmark of this disease is that loss of extension. Therefore, if a patient presents to you, okay, otherwise normal history, but the only problem is limitations in extending the toe, that should be at the top of your list. Right. What do you find on plain films? Everything that we just talked about, right? Look to your left, bottom, you'll see those osteophytes, right? Do you guys cover osteophytes in radiology? Okay. So you'll see these osteophytes very prominent in cases where it's very widespread. Then you'll have corns of calluses, right? Based on how it's rubbing against the shoe at that site. Again, like every other foot problem, give them the ugly shoe, okay? That ugly shoe does wonders. Rest, ice, activity modification. Sometimes we do some intra-articular steroids. You have to be careful though, because some of the steroids actually can contribute to degeneration of the joint space. Okay. This procedure you see here is what is called a cheilectomy, in which we remove the osteophytes, and in some cases they have a return to normal function. In other cases, then we just have to fuse the thing, and now they can't move it, but it's not painful, right? So we kind of denude the area, remove all the some of the cartilage, fuse it so the bones kind of fuse together, and send the patients on their merry way. Okay. Any questions on what we talked about so far? None? All right. I got a question for you. All right. Pay attention. So I've got a 51-year-old male that presents to me, or you, right, with a history of trauma, non-specific trauma. He doesn't say what happened. He just presents. He walks in, perhaps on crutches, because he doesn't want to weight bear on his right foot. Okay? He's sitting in your waiting room. Your medic brings him back to you, or your nurse brings him back, and you elicit from him that he was, part of a, was playing tennis, and had a run-in with one of his partners that hit him with his tennis racket. Okay? That's his history. Now, as you continue to assess him, you notice that his right lower extremity is severely swollen, right? He's got significant pain at the ankle. He's got significant pain at the distal aspect of his lower extremity, but the entire extremity from the knee down seems to be very swollen and bruised. Okay. What are you thinking? You're thinking Achilles tendonitis. You know what I hear? Oh, you're thinking Achilles rupture. Why? All right, so I'm hearing the history of the mechanism of injury. He's non-weight bearing. Okay, what would you expect to find? Because as you see this patient, now you start thinking of what's going on inside the leg, right? What would you expect to find? Okay, so you got a palpable defect where? That's the bookend, right? Okay, what else? Can you do a calf raise, right? And if he says yes, and he can do a calf raise, now what? Okay, hold that thought for a second. So you said you asked him to do a calf raise, right? Remember, you didn't want to walk on it, but he does a calf raise, right? What does that do to your one differential that you just had? All right. So now you decide to do a Thompson test. What would you expect to see on the Thompson test? No movement. If he can do a calf raise, will his Thompson test be positive or negative? Right? Right? So now what? Like what you think? What did you say over there? I'm not fighting you right now. You could get an MRI, but what would you do before you get an MRI? That's readily available in the center. An ultrasound, right? Okay. The ultrasound is inconclusive.
Not what you say.
I promise I'm not making this up. Maybe just a little. Right, so your ultrasound is inconclusive. Now what? You can get an MRI, right? Okay. So you find out that he's got what looks like a partial tear at the musculotendinous junction, right? And so, how would you treat this person? Cam boots, crutches, but what do you do before you put it in a cam boot? You rise it, right? Not say rising, but you know what I can rise him. So, okay. So you see how you think through this process? That's what your exam tests are going to look like. I promise I will not ask you, if a patient gets hit to the racket and presents, what is the injury? No. That was what you did as the medics. Right? You are way past that level. You got to think through. You have to know what the condition is, what the treatment is, and in some cases, what's the downfall of either treating or not treating. Trust me, you'll have plenty of time to practice. We'll go through different scenarios like this. Okay? Don't read into the question. Do not. I promise you. Don't add your own stuff in it. I do not want you to fail this test. I don't think he does either, right? So if it's not there, chances are, and there is no funny business. I get nothing out of having you fail other than one less PA that I need to provide to the force, right? It's not, that's, my goal is to provide PAs for the force, right? So having you fail the test is not my thing. However, you gotta roll with the punches. You gotta be strong. All right. See you guys tomorrow.